Yeah.
Mercedes S-Class, S560.
Green is there? I never knew.
Yeah,
You're
they
white?
made it for you, madam.
Okay. Yeah, leave it. Is it
Okay, we are live.
yeah. So, hello everyone. I welcome all of you for this masterclass on Saturday. So, Dr. Jay is traveling to Agra where he'll be operating tomorrow on endometriosis cases. So, today we wanted to discuss something very interesting, which we have received a lot of queries regarding how to tackle hyperprolactinemia in cases of infertility. So over to you, Dr. Jay. I think he gives very clear concepts about when to treat, when not to treat, and how much to be treated or what is over treatment. So over to you, sir.
Yeah. So, guys, I am actually on the expressway and I'll try to share the screen. If in case I go off, then Shilpa madam will be taking over the session. So, Shilpa madam, please keep on telling me if the screen is visible or not, okay? Because uh, I'm unable to see
Yeah, it's seen, it's seen.
through this. All right. So concept. Okay. One must remember really ignore prolactin thinking कि prolactin में कुछ is secreted. Okay. Just remember this prolactin and FSH LH मतलब GnRH agonist GnRH pulses from where they are released. They are very close to the region from where the prolactin pulsations are released. Just remember this much for your basic information. Okay. So what happens is when the value of prolactin goes up due to whatever reason. Okay. Commonest reason in India is hypothyroidism. Okay. Other commonest reason in India is due to any form of drugs. And third is idiopathic, very common reason. Okay. Idiopathic may there comes obesity. And then obviously then the other thing are tumors. Okay. Shilpa madam audible, right?
Yes.
So what typically happens is when the prolactin goes up, it causes GnRH pulsations to become abnormal. Okay, it causes GnRH pulsations to become abnormal. Now, when these GnRH pulsation become abnormal, the release of FSH and LH becomes abnormal. All right, and because the release of these two becomes abnormal, it causes problems as far as ovulation is concerned. As a result of which, the commonest problem which occurs due to hyperprolactinemia is hypoovulation. Okay, or anovulation. All right, just keep this in mind. Now comes the question, okay, I understand treating prolactin. What are the things about treat somebody with prolactin disorders? Okay, so there's a very simple flowchart which we follow. Okay, I think people can follow it if you want. So prolactin is to be tested preferably in the morning. Okay, preferably fasting sample in the morning. First morning sample is the one where it has to be tested because that is where it is at its lowest level. Okay, when you wake up in the morning, you jump around, you do some exercise, you go for morning walk, all these things, you stress yourself out, you do a lot of surgeries. In this that situation, the prolactin level can be falsely elevated. But when you have slept and when you've woken up in the morning, okay, that's usually the time where prolactin levels are going to be at its lowest. So that is one of the best times to go ahead and measure it. Okay, so just remember a morning fasting sample is the best measurement. Okay. After this, audible, Shilpa madam?
Yes, yes.
Okay. After this, we want to divide it into very simple parameters. Is the prolactin less than 20? Is the prolactin between 20 to 50? Is it between 50 to 100? Or is it more than 100? Khatam. That's it. Just four categories. There should be no fifth category inside all this. Nothing more than these four categories we are supposed to consider. In these four categories, you will come to know almost everything that you have to know as far as prolactin is concerned. If it is less than 20, answer is simple, no treatment. Okay. If it is between 20 to 50, Shilpa madam audible? If it is
Yes.
between 20 to 50, All right. Remember, this is something where it causes subfertility. Okay, you may feel कि अरे prolactin का value तो 32 है. Why should I give anything for 32? Remember, you should not give because at 32 ovulation will occur, but at 32 abnormal pulses of FSH and LH will also occur. FSH getting abnormal pulses is okay, the ovary will overcome. But when LH pulse becomes abnormal in this range, it can cause a defective corpus luteum. This defective corpus luteum can cause implantation failure. And because it causes implantation failure, you need to be careful. You need to give this patient cabergoline. All you need to give this patient is 4 tablets of cabergoline. Tuesday, Friday, Tuesday, Friday. Okay? Because cabergoline is a long acting thing. So 4 tablets is enough. That takes care of this problem and your subfertility, especially defective implantation, especially when you are asking the patient to do ovulation induction, natural intercourse, IUI, or modified natural cycle for embryo transfer, then this value is very, very important. And this is the commonest value which is ignored. In fact, if you look at my practice, I do prolactin for a lot of people. Okay. And this treatment here is something which makes the patient pregnant in the next cycle. This is a trade secret, but I'm still sharing it with you because it's important that people understand. More than 100, it is simple. Okay, you have to do an MRI brain and you have to rule out especially tumors. In this situation, again, the treatment is to give prolonged cabergoline. Okay, but really, you need to rule out at more than 100. There is no waiting period in this. Okay, now this is interesting, 50 to 100. Okay, see, prolactin, no, many a times what can happen is, let's assume this is a molecule of prolactin. Okay, I'm just drawing one molecule of prolactin. Sometimes 5 such molecules of prolactin will form clumps with each other. Okay, these clumps, no, are commonly called as macroprolactin. Okay, now remember, this macroprolactin has something which is a delayed clearance because they are large molecules of prolactin. Because they are delayed clearance molecules, it shows a falsely elevated value of prolactin because it has not been cleared nicely. This can simply be ordered the minute you have hyperprolactinemia. You can just ask your lab to check for macroprolactin. Okay, there is a PEG test. They use this reagent even in India, and they sequestrate macroprolactin, and then there is a computer generated algorithm which gives you value of macroprolactinemia. So if there is too much macroprolactin, okay, you know that the prolactin is not truly elevated in this situation, especially in this range. Okay, you can just follow up this patient. You can give cabergoline to these patients for approximately 4 to 8 dosages, and macroprolactin can be easily treated. But this is something which is really missed out. Understanding of macroprolactin gets missed out. Okay, and that is why as clinicians it is very important that we understand it. Okay, so this basically clears your understanding of hyperprolactin and management of prolactin, which is typically ignored. So does it mean that we need to check for prolactin in every patient who is coming to us for fertility? The answer to that question is yes, you should do it. Every patient who is reporting to you with fertility, AMH, TSH, and prolactin has to be mandatorily established. Okay. Why to give why to give cabergoline? Why not to give bromocriptine? Completely your choice, bro. Give what you want to give. Okay. You like to give prolactin? You like to give bromocriptine, give bromocriptine. You like to give cabergoline, you give cabergoline. I prefer cabergoline because it is just twice in a week dosage. Okay. It's very good. It's a twice in a week dosage. Before I finish my 15 minutes, I want to tell something important about galactoria. See, people often say that prolactin value is 135, but there is no galactoria. Okay, galactoria is not going to be seen in 100% of cases of hyperprolactinemia. Okay, it will be seen in only 25% or maybe 35% of the cases of hyperprolactinemia. So don't go by that. Don't go by the fact that why is hyperprolactinemia not seen. In order for somebody to see a hyperprolactinemia, there has to be a patient who is having breast glands which have a very good estrogen exposure. That is important. Okay, so when you have suppressed estrogen due to your fertility treatment, when you have suppressed estrogen due to any form, GnRH agonist or whatever you have given, right? In that situation, your galactoria is any which way is not going to be seen. Okay, so keep that in mind because people often miss out. They keep on changing laboratories, telling the patient that galactoria nahi hai na, so no need to worry. It's stupidity. Galactoria is going to be seen in 35% of the patients only. Second, if you give cabergoline, galactoria will not be treated tomorrow. Okay, it will take 2-3 months for galactoria to stop after prolactin becomes normal. Okay, it is not an immediate treatment. So even keep that point in mind because that is something which majority of the people uh, don't know, or probably majority of the people have forgotten. And one final thing, in India, in Indian circumstances, with hyperprolactin, the first thing you will pick up is hypothyroidism. Okay, it's the commonest. It is the commonest thing. Okay, so you'll pick up hypothyroidism. Don't miss out on that. And finally, one common question majority people will ask even in the chat box. Okay, I have seen a patient who is having galactoria, but the patient is having normal prolactin. How on earth is that possible? It is absolutely possible. A patient whom you think is having galactoria will have a prolactin of, let's say, 24. Okay, that is possible. That is still above the range of less than 15 or less than 20, which is the basal level of hyperprolactin. Okay, so it's possible. You need to give that patient 4 tablets of cabergoline. Don't eat your head up. If the value is less than 50, 4 tablets of cabergoline. Value is more than 50, you may give it 12 tablets. That is 3 months. Okay. Value more than 100. Don't try to be over smart endocrinologist. Two people should treat. You should do tumors and all these things or those evaluate. But for fertility purposes, just follow this guideline. And this guideline should be more than enough henceforth in tackling patients with hyperplatinum. Okay. Shilpa madam, over to you.
Yeah. So what about association of polycystic ovaries with hyperprolactinemia? We see this very often.
Commonly seen, madam. It's a very common thing to have hyperprolactin with polycystic ovaries. And one of the reasons because that happens is due to abnormal estrogen. Okay, and the abnormal LH pulses, both of them. That is why when you give OCPs, when you give Crimson 35, when you give any of these combinations to treat PCOS, you will often see that the prolactinemia resolves.
Okay, tell me this thing. See, how much is the low prolactin levels? Like, how much do we suppress? So you say that you give only 4 doses and you don't recheck it. I mean, we have seen, I have seen especially people over treating hyperprolactinemia. They give
See,
this.
people love that prolactin has to be suppressed till a value it is undetectable. There is nothing like that. Okay, prolactin less than 10 is the target. So once you give 4 tablets of cabergoline, don't go and repeat prolactin next day morning. You have to wait for another 2 to 3 weeks and then repeat to see if your cabergoline has actually gone and acted nicely. Because the day you give cabergoline, prolactin mar jayega. Prolactin will not be present. Okay. Similarly, if you have given 12 tablets, wait for another 1 month and then check the prolactin. Similarly, when you give thyroid medications, when you have hypothyroidism, okay, detected, which has caused hyperprolactinemia, thyroid medication will be required for 6 to 8 weeks before prolactin comes back to normal. Keep that in mind.
Yeah. So, see, we see this over treatment of prolactin where I have seen that, like, patient was on cabergoline twice weekly for almost for 1 year. Okay. So,
Yeah. 1 year is common.
no, how can it be common? See, we are treating not
Madam,
like.
full family's prolactin will become normal if they are treated for 1 year. Trust me. Not family, full city. Bangalore's prolactin will become normal. It's like that. By
You can't.
mistake, if she gives that, mixes that tablet in the husband's milk, no, he will have impotence for 1 month. It is like that. Seriously.
You can't answer like that. You should say, like, okay, maximum how many doses? See, what people usually
No.
do
So
is.
12 tablets is something which we have to keep in mind. Anything as a fertility specialist, if we have to give for more than 3 months, that is more than 12 tablets, always and always take help, reference, and involve your endocrinology friend inside this, please. Because prolonged therapy of cabergoline, though it's nothing that it causes a major problem, but it is always good and medico-legally safe to have a documented signature of an endocrinology reference also. If you don't have an endocrinologist, then a physician reference is also fine.
So you mean to say 24 doses of cabergoline or 12 weeks of cabergoline, right? I mean, that's what
12 weeks of cabergoline, correct.
So see, is it like, okay, if the value is 30, you give only 4 tablets. If the value is 60, you give like 12 tablets or 8 tablets. Do you depend or do you titrate it on the value of the prolactin, or it's not required?
Very simple, madam. If the value is between 20 to 50, you give 4 tablets. If the value is between 50 to 100, okay, you give it for 12 weeks. If the value is more than 100, involve an endocrinology friend with your treatment. Simple.
Okay, so you have given, see, a patient who has a prolactin of, say, 45, and she is hypothyroid. So you have treated both, like you have started treatment for both. So you give them 4 doses of cabergoline, and you start whatever required dose of the thyroid medication. So after how many days or how many cycles you start stimulation?
After one cycle, that means, let's say in the month of December, if I've given prolactin, then I can start the stimulation from the February cycle. That means January cycle I have to skip, February cycle I have to start the stimulation.
Okay. And so we see this recurrence of this the prolactin issue. So 1 year you give them and it will come down. Then the next year you repeat it again. I mean the same that abnormal value will be there. So do you treat them again?
Yes, madam. That is predominantly due to obesity. That is predominantly due to PCOS, as you have mentioned. Okay, or due to thyroid fluctuations. If a patient is hypothyroid, no, this hyperprolactin value will keep on going up and down with the variation in the thyroid titers which they have. Okay, so when they have something like this, it is better to treat them when you see them.
Okay, see this prolactin levels being high. Have you noticed it in omeprazole and ranitidine taking patients? Because that was one of the things.
More common with psychiatric medications as compared to, much more common with psychiatric medications, madam, as compared to the medications which you mentioned, PPI and proton pump inhibitors and all. Though it is good to read, but I have not seen it very commonly, madam. I have seen it very commonly with psychiatric medications.
Okay, okay. So this galactoria, see, sometimes it is kind of a little weird. See, sometimes they just come with watery discharge, and then the next day they come with milk-like discharge. So blanket is only the treatment is prolactin, the cabergoline, is it?
No, not at all. Breast discharge is a completely different topic. See, when you have when you have one thing which is important, okay, about galactoria due to prolactin, okay, is that usually it will be bilateral, usually, okay, and second, usually the discharge will come from the entire periareolar region, madam. Okay, if it is coming from only a particular point in the areola, only one of the duct, if it is coming from, then it is to be treated as a abnormal breast discharge and not galactoria. This patient is going to require antibiotics instead of giving cabergoline. Okay, if it is just a singular cyst discharge, because it is very difficult to practical purposes differentiate that is it actually milk discharge, or is it just an abnormal watery discharge. Very difficult in clinical practice to accurately distinguish between all these things, especially for male gynecologists, despite having a female nurse who is present.
Yeah. So see, prolactin, how much importance do you give this in your practice? Like, say, for IVF stimulation, patient has come all across, like,
every patient will do prolactin.
No, but they have come from some other country. They are all ready for the stimulation, and you see that the prolactin levels is like normal range is say 25, and you see that the value is 29. So do you postpone the cycle?
To give Not at all. In that particular situation, there is something which we, where you use a big dose of prolactin, which you use to stop lactation. So, what is the dose which is used to stop lactation? Is 0.5 milligrams, 2 tablets. That means 1 gram of cabergoline is given stat dose. Okay, after a second trimester abortion to stop lactation. Even after giving that tablet, right? In that type of a situation, one should not postpone a cycle. One should not cancel a cycle if patient is okay, Monday, Tuesday, Wednesday, like that, and go ahead with IVF stimulation, IUI stimulation.
Okay, so your voice broke in between. So you're saying you give 2 doses of cabergoline, 0.5 mg, OD for 2 days, and then you go ahead with your stimulation.
That's it.
Okay, fine. So what is your, wherein you postpone the cycle? Like, is it 50? Is it like 60?
Prolactin more than 100. If the prolactin is more than 100, okay, madam, then your follicles will most probably turn out to be empty follicles. Your oocyte to follicle index will be severely altered in hyperprolactinemia.
Okay, so what is your protocol? Like in the same cycle of IVF, you always do a prolactin, even if it has been done like 4 months before, 3 months before, you insist on doing a prolactin level before you start the stimulation?
If they've come to me on the day of stimulation to directly see me and just start the stimulation, then yes, on that day. But most of the times, I would have seen the patient 1 month before and then they are coming for a stimulation. Even if you are talking of patients who are coming from abroad, I know who is coming from abroad. So usually they would have been evaluated for thyroid and prolactin, madam.
Okay. So do you see that prolactin levels increase after you have stimulated in IVF? I mean, have you come across cases where you have used higher doses of the HMG and then you see the prolactin levels subsequently have increased, like when you try and do a second cycle or third cycle of IVF for them? Have you noticed? Not really, right?
I have not seen it. I have not noticed.
Okay, yeah.
No, madam, I have not seen.
Okay, so I think that's about it related to fertility. Yeah, so you said you see empty follicles when the prolactin levels are more than 100. So if it is, say, hovering around 50, so and you come to know about it in the mid-cycle for an IUI, you cancel the cycle between 50 and 60? No, sorry, you need to tell it all over again because your voice is lost.
Stimulation will be very poor, madam. It will be. Yeah, Shilpa madam, hi. The cycle has to be cancelled.
Okay. So you cancel the cycle when it is. See, off late we are seeing in some months so many prolactin levels will be high, and in some months, like I mean, everybody's will be normal. So you see a seasonal variation in this prolactin?
No, I've seen people abnormal in every month and normal in every month. Nothing like that, madam.
Nothing more like that. Okay. Yeah. Okay. Yeah. Thank you so much.
Maybe getting intimidated of you, or scared of you. So that's why their prolactin is going up.
Please come on. Okay. I mean, I just saw 4 reports of prolactin. Like everyone is having between 50 and 60. I was like, see, I usually don't overtreat the higher prolactin. I usually give only 2 doses. You give 4 doses. I give only 2 doses in my practice because I see like suddenly that 0.5 milligram, no, it suppresses too much. What I had observed